lot of you know that one of the goals and fundamental missions of C3 is to prepare our next generation of cardiologists and interventionalists all throughout the world. You know, we make tremendous investment every year in younger physicians, you know, by providing them all types of resources for C3 meeting. And I like to continue to have that dialogue ongoing. So I think Dr. Kumar and Dr. Magdy has really worked very, very hard. We have had record-breaking submissions for year 2020, which we couldn't do because of the COVID. But we're going to continue to have this dialogue and discussion so that we can continue our learning as we go. We hope that you know, the COVID situation gets better and the vaccine is available so we can do 2021 meeting. We have announced the dates already, you know, when we postponed the meeting for this year, which is supposed to be in the last week of June. And I think that in very near future, we'll start accepting submissions for C3 2021 as well, immediately after November. Once we have a little bit of a clarity about what's going to happen next year. So without further ado, I'm going to turn it over to Dr. Kumar now. He'll start the program and we'll continue with the discussion.
Perfect. Good morning, everybody, and welcome through this online fellows case bowl presentations. On behalf of C3, I would like to welcome all of you again. Again, I would like to go ahead and take a few minutes to introduce myself, and I'll have my panelists introduce themselves. My name is Gautam Kumar. I'm an interventional cardiologist at Emory University and based predominantly at the Atlanta VA Medical Center in Atlanta, Georgia. Ahmed, maybe you start.
Good morning and good afternoon for everybody. It's my honor, pleasure sharing in the scientific educational webinars of C3. My name is Ahmed Magdy. Most of you maybe know me. I'm the past president of the National Institute in Cairo. I'm the national ambassador or international ambassador for the SCAI and the course co-director of C3. And also I'm the chairman of the Egyptian Fellowship Board of Interventional Cardiology. And I'm glad to be here to this afternoon sharing with you your cases. It's always my pleasure to work with Rajesh, please.
Good morning. My name is Kusum Lata. I'm one of the interventional cardiologists. I practice with Sutter Health in Bay Area, California. Thank you so much to Dr. Dave, Dr. Kumar, and C3 for introducing me to this really wonderful session. And I'm looking forward to listen to all of you and learn from you. Thank you.
I'll go ahead. I'm Arun Kumar. I'm an interventional cardiologist at the University of Missouri in Columbia. And again, thanks to everyone, Dr. Dave, Dr. Kumar, and all the attendees for being part of an exciting session.
Excellent.
Hi, I'm Rajesh Sachdeva. I'm a professor of medicine at Morehouse School of Medicine. I'm also a staff physician at Atlanta VA with Gautam. And thank you, Dr. Dave and Gautam, for letting me part of this. And looking forward to an exciting Fellows Forum.
Here, Pancholy from Northeastern Pennsylvania. I'm a professor of medicine at Geisinger Medical College and an interventional cardiologist in Scranton, Wilkes-Barre, and a partner in C3 since its inception in Harrisburg.
Hi, I'm Dr. George Vetrovec, Professor Emeritus, Virginia Commonwealth University in Richmond, Virginia. This is going to be a fun session, lots of great cases, enthusiastic young presenters, so I'm looking forward to it.
Excellent. Okay, I think we have covered all the panelists. I hope I didn't miss anybody. Nope, I didn't. Okay, very good. Now I think that leaves us time to move on with the very first case, and I think it's going to be by Dr. Sheikh.
Was it me? Okay, right. Yes, bring my slides on. Right. Can you see my slides?
Not yet. Share your
No, not yet.
Okay.
You probably have to hit the share screen button at the bottom.
Just give me a second. Share. Give me a second. I'll just. Can you see my slides now?
Yes, we can see your
Yes.
slides, and if you hit the slideshow, I think it'll go on the full screen. Dr. Sheikh, please introduce yourself. Tell us where you're from.
Yeah, thank you very much. Thank you very much, C3 team. My name is Azim Sheikh. I've just finished my post-CCT fellowship at Portsmouth, and I've just started as a consultant interventional cardiologist in Birmingham here, actually in UK.
Welcome.
Thank you very much for giving me an opportunity. I'm going to just present an interesting case of a 57-year-old lady. So the bit of a weird story actually. So she self-presented to district hospital initially with some left leg numbness and pain and hip pain, and there was a suspicion of a cauda equina syndrome. So she came under the medical team and was seen by the orthopedic guys and was booked for an MRI scan of the spine. So whilst waiting for the scan, she developed some chest pain early morning next day, and ECGs at that point demonstrated anterior ST elevation. And she was transferred across to PCI center where I was working for consideration for a coronary intervention. Background, usually fit and well. She did have a history of rheumatoid arthritis, asthma, and hypercholesterolemia. So these were the pictures. Sorry, I've had some problem with my video clips this morning. I imagine you can still see them. So the right coronary artery, as you can see on the left of the screen. Give me a minute. It should come up. Seem to be playing intermittently on the videos.
You could try going back one slide and then come back forward and it should restart.
Right. Let's try again. Okay. So sorry for the problem. So let me just play again. So the right coronary artery was essentially normal. Let's see. Apologies for the technical. Let me see if we can play this one. Okay. Let me go back and.
Or you can skip the full screen and even work it on the regular screen.
Yeah.
It will work. It's heavy, yes.
Okay. I'll try that then. Just trying this. Come out of the full screen. Okay. Right. Let me try this one.
Yes.
Okay.
Try.
That's better. Okay. Thanks.
Yeah.
So right coronary artery was essentially normal. So this was the LAD. Let's play this one. So you can see the LAD was occluded in the mid vessel, and you can see some dye hang up in the mid vessel there actually. Go to the next slide. So So this is another cranial view, occluded LAD with some dye hang-up, and these findings are suggestive of possible spontaneous coronary artery dissection. So she was still had ongoing chest pain, and STs were still elevated in the anterior leads. So what we did was we put the wires down. We used 2 turn track wires, one down the LAD and one in the circ. Because the guide, we had some difficulty in getting the guide into the left main. So the next thing we did was we used a semi-compliant balloon. This is just a still image actually. So we used a 2.0 by 15 balloon and pre-dilated the occlusion point. So this was the post-balloon dilatation picture. You can see there was no flow down the vessel still in the LAD. Again, you can see this is another picture. This is not great flow down the LAD. Following this, we used an emerged semi-compliant 2.5 times 15 balloon and pre-dilated it again. And we took, this was a picture again after the second balloon dilatation. Again, no great improvement in the flow in the LAD after the balloon dilatation. So the patient at this point was still having chest pains, and STs were still up in the on the ECGs. So at this point, we decided to perform a cutting balloon angioplasty to create communication between the true lumen and the false lumen, and to reduce the compression and restore the distal coronary blood flow. So we used 2.5 times 10 cutting balloon flex dome, and we went up to a low pressure, just about 4 atmospheres. I'll show you the next picture. So we managed to get some TIMI2 flow down the vessel after this cutting balloon treatment. At this point, the patient, the chest pain settled and the ST is completely resolved, and she was hemodynamically stable. So we decided to stop at this point. This was the last picture. You can see some TIMI2 flow down the vessel. We took her back to the ward, to coronary care unit for closer monitoring, and we recommended aspirin for life and clopidogrel for 3 months. At the moment, there are no clear guidelines with regards to antiplatelets in patients presenting with SCAD, and it all depends upon the operator's discretion, and we recommended clopidogrel for 3 months. So she remained stable on the ward, and she was discharged home on day 5, actually. This is just an overview of a SCAD. So SCAD is an important cause of acute coronary syndrome, particularly in young women without traditional cardiovascular risk factors. The pathophysiology and treatment are different to acute coronary syndrome caused by plaque erosion or rupture. Conservative management is preferred in stable patients with SCAD, as most dissected segments will heal spontaneously. Medical therapy is based upon opinion, as we do not have any randomized trials to date. The stenting is preferred revasc strategy, but is associated with significant challenges and has a low success rate of less than 50%. With coronary stenting, there are technical challenges, which would include negotiating the guide wire into the true lumen, propagation of dissection, and hematoma extension and side branch occlusion. Stent placement can result in hematoma propagation and loss of vessel flow. The stenting should be performed by experienced operators with the use of intracoronary intravascular imaging, preferably with an on-site surgical backup due to increased risk of complications. Surgery is considered for patients with left main dissection, or one PCI has been unsuccessful or is not technically feasible. Although long-term prognosis is excellent, the risk of recurrent SCAD events is significant, with an average rate of about 5% per year. The use of cutting balloon to treat SCAD is a novel technique with only small number of reported cases worldwide to date. The idea behind it is to create fenestration in the tunica intima to drain subintimal hematoma into the true lumen, which is thus decompressed. We suggest using small diameter cutting balloons, at least 0.5 millimeters smaller than the arterial diameter. And we also suggest inflating the cutting balloon to low pressures up to 4 atmospheres to minimize the risk of perforation. So in brief, the use of cutting balloons in a patient with SCAD requiring angioplasty can be performed safely with resultant improvement in antegrade blood flow in vessels compromised by subintimal hematoma. But this needs to be considered with caution. Thank you. Any questions, please?
That's a great presentation. Thank you very much. I guess I have a question for you.
Yes, please.
Now, if you were to go back and look at this case at the very beginning, given the fact that there is no flow down that LAD and patient has ST elevations and ongoing chest pain, what are your thoughts regarding adjunctive management with agents like 2B3As and things like that, for example?
Yes, certainly 2B3A. We didn't use it actually, but it can be considered in these sort of cases. The other thing which we did not do at that point was intravascular imaging actually, because the patient was a bit unstable and she was having chest pain and ST elevation. So we thought probably get the flow down the vessel, and if she's stable, then best to stop there. Again, there are no clear guidelines with regards to 2B3A inhibitors in patients presenting with SCAD actually, but certainly people have used it in the cases reported previously.
Yes, Dr. Vetrovec, did you have anything to say?
I guess I'm interested in a couple of things, particularly what happened to the LV function in this patient. She was ischemic for quite a while, and she went home doing all right, whatever that means. I'm just curious about what, if any, long-term residual she has.
So she had an echocardiogram before discharge, and that demonstrated mild LV systolic dysfunction actually, and there was nothing significant on the echo actually.
Now that's great.
How about Dr. Kusum Lata?
That's a good recovery. At what point would you have considered a stent?
Yes. So if he, it's difficult. I think the current, what I gather from the recommendations is mainly when, if the patient is hemodynamically unstable, even after using these, then stent may be considered actually. But it's always technical challenges in putting the stents in. And we did not have a surgical backup on our hospital actually. So we decided, as the patient was stable, we decided to stop. But I think stent can be considered in people when they become hemodynamically unstable.
So I'm curious somewhat out on whether it's a benefit long-term or not. Particularly, that was a sort of intramyocardial segment. So I think you made good decisions. I'm not saying it needed a stent. I'm just raising that question because I think it's an interesting discussion point.
That's right, yes.
How about you, Kusum?
So I have a couple of questions. One is, do you consider doing a CTA as a follow-up imaging just to look for the patency? I'm not sure whether it's going to change the management. And the second question is, when the patient has LV dysfunction, will you consider cardiac MRI at least to see the amount of injury for the myocardium so that we can follow up and then, the patient, it can get worse. How much is the myocardium involved, heart failure therapy and everything?
Yes. Yes.
And then further, I would ask is, do a CTA to find out if this is associated with fibromuscular dysplasia.
Yes, CTA, we did consider that, and she was actually booked after discharge for an outpatient CT coronary angiography. We did not book her for cardiac MR, but certainly that can be considered if the LV, because she did have some LV dysfunction.
No, Dr. Sheikh, I think what Dr. Sachdeva is saying is not outpatient pulmonary angiography. I think what he's saying is outpatient head-to-toe CT angiography to look for fibromuscular dysplasia because it is commonly associated with SCAD.
Yes, certainly that that should have been considered. Yes.
So, Gautam, I'd like to make some comment here.
Sure.
Yes, please.
Yeah, first of all, cases of SCAD, actually, there is no clear cut in diagnosing if this was true SCAD or not, because yes, maybe we see some linear changes in the luminogram, but we are not sure. But sometimes we need to be with you in the cath lab to see it clearly, because maybe the angio by itself here is not very clear. And so making that the diagnosis, accurate diagnosis, sometimes is difficult. And we know that is not something common. It happens when in young women, and so making diagnosis is important. And the second thing is the classic teaching and our experience is just spontaneous dissection. It may heal, and there is no need to do intervention. Here you try the balloon first, but before the balloon, the flow, it was even better until you use the cutting balloon. So do you think if you have just made the conservative treatment and you observe and give the medical treatment and you didn't do anything, do you think using the cutting balloon was the regular balloon, then cutting balloon was better? And do you have experience with other patients? Do you have serious patients with cutting balloons? I mean, what is the rationale? Yeah, you explained the mechanism that may help, but did you have previous experience with that before?
Yes. So in our center, we've most of the SCAD patients, they are managed conservatively. But in this case, when we took the pictures, even after balloon dilatation, there was not much flow down the LAD, and that's why we use the cutting balloon. But I think the preferred way of managing these patients is still conservative management if they are stable.
Yes, because actually, since maybe 30 years or since the beginning of stents, we knew that putting the dilation of these lesions and putting the stents may be associated with stent thrombosis immediately, or maybe the dissection extends to other segments. So it's still a conservative treatment until you tell us that, yeah.
Yes, I agree with your comments.
I think the strategy you took to intervene on this vessel was right, because the patient was having ongoing chest pain along with ST elevations, and you were able to cross that lesion, and you initially tried to restore flow because there was no flow or TME1 flow. So I think it was important to establish flow at that point. But I think after establishing the flow, I would have gone a step further to establish the diagnosis of SCAD by doing an intravascular ultrasound or OCT if available, because then you have established the diagnosis that this was a patient with a SCAD. On the other hand, there will still be a question whether the dissection or a hematoma could be as a result of the balloon angioplasty which you did. So I think once your wire was across, if it was me, I would actually take the, either a IVUS catheter. OCT will be difficult because you won't be able to visualize distally. Take an IVUS catheter and establish the diagnosis that this is somebody who has dissected with an intramural hematoma, and that intramural hematoma is compressing the lumen and resulting in a decreased flow, and not a plaque and plaque rupture. So I think that I would have gone that route instead of just going forward and doing a balloon and going next to the cutting balloon.
Absolutely agree with your comments. The reason we didn't use intracoronary imaging is because she was very unstable when she came in, and we managed to get the flow, and then she was stable at that point. So we decided not to do any more intervention at that point because she may become unstable again. So we stopped at that point. But certainly, absolutely, intracoronary imaging is very important in making the diagnosis.
if we have time for one more question, if that's okay. So Dr. Sheikh, or to the other panelists, what are the thoughts about either going back in, maybe do a relook, and if you do that, at what time, or with additional imaging? We had a similar case this week, and it's the final result on the initial angiogram is rarely satisfying. It's something we wouldn't like to walk away from, but in these cases we do because we've restored flow. Just some thoughts on follow-up imaging, either maybe even invasive, as far as going back in the lab to relook at a later time.
Yeah, so in terms of imaging for a follow-up, we booked this lady for a CT coronary angiography actually, and I think that would help in making the diagnosis as well.
Okay, very good. Thank you so much.
Thanks very much.
Thank you.
Thank you. Bye-bye.
Now it gives me great pleasure to go ahead and introduce our next presenter, Dr. Sarah Doleeb. Sarah, are you there?
Yes, can you hear me?
Yes, good morning.
Good morning, thank you for having me.
Very good. Are you able to share your screen to us? And maybe you can stop sharing. Yes, I guess you've done that. So Sarah, are you able to share your screen?
Okay, I will in a couple of seconds.
There is stop sharing. No, not share screen, stop sharing.
Okay. I think we have your screen there. Very good, Sarah. Where are you from?
I'm a cardiology fellow second year at Advocate Lutheran General, Illinois.
Welcome. It's a pleasure to have you.
Pleasure is mine.
Yes, and looks like you're going to give this, hopefully you'll give this intervention a good name and not a bad name.
Can you see my screen?
Yes, absolutely.
So today I'm presenting kind of a challenging case. We haven't seen it in our institution. It was like very unique. A 28-year-old male who was brought to the Lutheran General Hospital emergency room as a trauma alert. He had through and through gunshot wound to the left side of the chest in a drug deal that went bad. He does not have any significant past medical history or family history. His social history was significant only for marijuana use, no cocaine use. Initial evaluation by trauma team, he was awake and alert. He was agitated, hypotensive, and tachycardic. Physical exam showed decreased air entry to the left side of the chest, and the entrance wound actually in the anterior left side of the chest, and the exit wound towards the left lower part of the scapula. This is the initial X-ray, which showed massive hemothorax. He had emergent chest tube insertion, which drained 2 liters of pure blood. And this is the X-ray following the chest tube, which showed some improvement in his lung on the left side. The injuries that documented in the emergency room, gunshot wound to the left side of the chest, which resulted in left-sided hemothorax and comminuted fracture of the left scapula. He was resuscitated, received blood transfusion, IV fluid, pain control. This is his lab, nothing significant apart from blood loss anemia, and initial troponin was mildly elevated. Trauma team did EKG, and this was the EKG. So as we can see, the EKG showed sinus tachycardia and diffuse ST segment elevation mainly in the anteroseptal and also in the lateral leads, with some reciprocal changes in the inferior leads. Subsequently, they obtained an echocardiogram. This is for apical 4-chamber view, which, as you can see, showed low EF, maybe 30–35%, akinesis of the apex, and hypokinesis of the anterolateral wall and apical inferior. Another 4-chamber view. And you can see also mild pericardial effusion. Imaging was slightly challenging because of the wound and the dressing, so the team tried to do their best to obtain images. And this is the apical two-chamber view. As we can see, low EF and apex is not moving. And this is definity for chamber and two-chamber view. So the report 30 to 35% EF, akinesis of apical myocardium, and severe hypokinesis of apical anterior, mid-anterior septal, hypokinesis of the mid-inferior septal and apical septal, along with a small pericardial effusion. At that time, cardiology team was involved after the echo was resulted. When we got involved, we got check another troponin, which peaked at 200. I went to the bedside, evaluated the patient. He had mild, some vague left-sided chest pain, and it was mainly positional. And he was in sinus tachycardia. So with this EKG and with this wall motion abnormality, all of this go along with anterior STEMI, proximal LAD occlusion. But actually the challenging is he's a 28-year-old with no traditional risk factors. So what's the odds that he would develop anterior STEMI at the time he had a gunshot with no any risk factors? But all the evidence, when you put it together, it points toward anterior STEMI. There could be other possibility, Takasubu, maybe coronary artery dissection, it could be contusion, but troponin of 200, it's very, very unlikely to be something other than ACS. So we had a multidisciplinary discussion involving our cardiology team. We talked to the trauma surgery, cardiothoracic surgery, and vascular surgery. We told them this is what we think is going on, and we really need to have a look, take the patient to the cath lab. But he had like massive hemothorax, and he had 2 liters of blood drain from the chest tube. We concerned about a major vascular injury, and this is only thing that maybe have us delay the intervention. So with this discussion, we had a CTA which was obtained at the time of admission. It's been again revised by a vascular surgery and radiology, and they reassure us that there is no any arterial injury at this point. So at this point, we took the patient emergently to the cath lab to explore what's going on. And we have the OR open just in case something went wrong. The trauma surgery and the CT surgery were right at the cath lab with us watching the procedure and helping as a backup. The right femoral approach, the left coronary was engaged. We obtained diagnostic angiogram. This is RIO caudal view, which as you can see, complete occlusion of proximal LAD. And as the actually contrast wash off, the contrast is still hanging there. So there is a possibility of occlusive thrombus there. This is another LAO caudal view, which confirms the proximal LAD occlusion. Another view. And as we can see also, there is no evidence of any atherosclerosis disease otherwise in the coronaries. The right was normal. So following the diagnostic imaging, we had a 6 French ABU catheter, 3.5 guide wire used to engage the left coronary for intervention. And then 0.104 by 180 centimeter run-through wire was used to cross the lesion with minimal difficulty. The wire was placed in the distal LAD, and then afterward, we have 2 by 8 millimeter over the wire balloon was placed in the distal LAD, and there was some blood draw through the lumen, and then the distal intraluminal position of the balloon was confirmed by using contrast dye, as we can see. So we made sure that there is no dissection and we are intralumen in a true lumen. At this point, we made a decision to do aspiration thrombectomy using penumbra catheter, which basically wasn't successful. At this point, 2.5 by 30 millimeter balloon was used for angioplasty, which was successful, as we can see here. There is some flow established. Afterward, we decided to do an IVUS to look for any other possibility. And this is pull back. There is no evidence of atherosclerotic disease, but we can see a hematoma, subendothelial hematoma over here, that obliterating the vessel. And we can see it clearly here as well. And at this point, we proceeded with a stent because of no flow. We deployed 2.75 by 38 millimeter, a drug-eluting stent, and we post-dilate by 3.25 by 20 millimeter with a compliant balloon. The flow we got actually was TEMI-2 flow. So we use intracoronary nitroprusside 200 and nitroglycerin as well, with improvement of the flow to TB3. And as we can see, it's a long wraparound LAD. This is another one after intervention. So with this result, we were happy. Patient continued to be hemodynamically stable. ST segment depression, actually ST segment came down, improved. He was taken back to the surgical ICU. He was started on guideline-directed medical therapy, repeated echo in 2 days after the intervention. Unfortunately, his EF is still 30-35%. And he tolerated the dual antiplatelet therapy with no any incident of bleeding. And his hospital course was prolonged by MRSA infection. So type 1 MI defined according to the first universal definition of MI is a detection of a rise and fall of a troponin at least one value above 99th percentile with either acute myocardial symptom like acute chest pain, new EKG changes, development of pathological Q wave, evidence of a loss of myocardial viability, or identification of coronary thrombus angiographically or with intracoronary imaging like IVUS. This is a very rare presentation of a penetrating trauma to the chest causing LAD hematoma and anterior STEMI. Unfortunately, the presentation in this situation will be masked by the original trauma. We propose, we don't know, we kind of look around and nobody have seen this before. So we kind of went to the literature and tried to see what's the mechanism of having such LAD occlusion in a very young age following penetrating trauma. We propose that probably the pathway of the bullet created blast injury, which caused endothelial injury and subsequent hematoma formation and thrombus formation. And this is what led to occlusion and obliteration of the vessel. Diagnosis really needs a high index of suspicion, maybe obtain serial EKGs and an echocardiogram early. As I said, in the literature, we found like scarce report here and there about penetrating trauma causing such presentation. Interestingly, some couple have done interventions the same we did, and some managed conservatively, and they have reasonable results as well. By this slide, I will come to end of my presentation.
Excellent presentation there, Sarah.
Thank you.
And that's actually a great case. I wanted to start the ball rolling by asking, throwing the question over to one of my panelists, Dr. Sachdeva, who also works in a major trauma center here in Atlanta. How often do you see something like this? How often is actually interventional cardiology? Maybe we can also poll the panel here. How often has interventional cardiology ever been called to the ER to see a post-traumatic patient in any way, shape, or form?
Well, I would say because I work in a great hospital, not, it happens frequently at Grady because we are the major trauma center, level 1, and we get pulled out to see some of these trauma patients. And, it happens to be sort of a coincidence that we recently had a similar situation in a 33-year-old patient who had come in with trauma, but he actually had ruptured bladder and broken femur and had undergone surgery. And me and Gautam were both involved in the patient's care. But before I actually go on to talk about that patient, I would ask you a question about how, what was the sort of a time lag from the initial diagnosis of STEMI to the cath lab? Because I saw that you guys had done troponins, guys had done echo, a contrast echo, and reviewed the CTA, which was performed, or CT, which was performed, I guess, for trauma series, as a part of trauma series.
So there were a time lag. Cardiology team actually involved almost like 6 hours after the presentation.
Okay.
Yeah,
And,
because the EKG was done initially, and I believe nobody reviewed the EKG from surgery. And by the time they did the echo and they found the wall motion abnormality, actually they were concerned about the wall motion abnormality. When the cardiology team 6 hours later came and we reviewed the EKG, we look into the echo, it was already 6 hours later.
Okay. And to the cath lab, how much time was there? So how much time it took?
It took us because it was a discussion back and forth. Taking somebody who just got a trauma and pneumothorax, we want to make sure that, administering anticoagulation is not going to cause more harm and more bleeding. We had to reach out to the CT surgery with everyone. It took us around 2 hours actually to get everything together and make sure we are on a solid ground taking this young guy to the cath lab.
I think I commend that. These are difficult cases. And it's to pull everybody, to bring everybody on board is also very challenging, that you guys are able to do in a relatively short period of time, given the fact that, he has come with a gunshot wound. So to go on to my patient, so we had this guy who actually was treated for trauma initially, had signed out AMA, and had come back after 6 days with abdominal discomfort. And it was thought that he had acute abdomen with air. And it was during that, a EKG was also performed, which showed anterolateral STEMI. But he had absolutely no chest pain. So this particular patient, because he had an acute abdomen, a surgical emergency, he was sent to surgery, and he underwent surgery, laparotomy and whatever they needed to do. And then after that, he was brought to the cath lab. And mainly the reason for bringing her to the cath lab was to establish the diagnosis, what was going on, because, these people are young, so SCAD is there. Then you also think about, was this an embolic event? And especially in COVID era, we are seeing a lot of unusual cases also. And I saw that this was pre-COVID, this case happened in January. We have seen very unusual sort of cases. So that was a concern. And then, the garden variety plaque rupture. It can happen, but it's unlikely in a young person without risk factors, but it can happen. So in our case, it landed up to be a haziness in the proximal LAD with the residual clot in the distal LAD when we cast him. To further clarify, I had to do an intravascular ultrasound and an OCT to establish the diagnosis. And I found that this was mainly a thrombus in the proximal LAD. And this was as a result of a plaque rupture. I could not demonstrate plaque rupture underneath the thrombus, but you could see the thrombus was adherent to that plaque and there was a plaque. So coming to your case, I think on the IVUS, I'm able to see that there is a plaque. I don't think that is an intramural hematoma because I can see the intima behind that thrombus. And I think this may be another case of plaque rupture. And number two, if you see your last image, there is some disease in the distal LAD. And also where the thrombus is, if you look at the IVUS, there is some degree of plaque formation distal to that thrombus on that IVUS. So I think this may be a plaque fissure, may not be a true sort of a ruptured plaque, but it may be a plaque fissure, which led to a thrombus formation and acute occlusion of proximal LAD. This is sort of a garden variety acute myocardial infarction, but happened in the setting of trauma.
I'd just like to applaud you, Dr. Doleeb, for taking this patient to the lab. I think this could have been easily ignored as stress cardiomyopathy. I think a gunshot wound is a stressful event, and sometimes folks talk themselves out of going to the lab. So I think that was a great idea. Saved this person's life, it sounds like. There's a couple questions from the Q&A on the chat, so I'll just ask those from these attendees. One question was, how much did you modify your anticoagulation, basically, given that there was a chest tube in place and given all the trauma? What about short-term antiplatelet management post-procedure down the line? And then just as far as management, did this patient have to go for other surgeries, and now you've got the patient on dual antiplatelet? Can you speak to that?
So regarding the anticoagulation throughout the procedure, we've been adjusting his ACT to be around 250 because by the time we took him to the cath lab, we made sure there is no more drainage from the chest tube. So, and trauma surgery, we're okay with fully anticoagulation. So the procedure was, it wasn't that long, but relatively long. We try to keep him anticoagulated as much as we can, and we maintain his ACT around 250. Dual antiplatelet therapy was then continued. He did not go for any further surgery. His fracture was managed conservatively because, benefit outweigh risk. We cannot stop. It's a very long stent, 38mm stent. We cannot risk at all any stent thrombosis and stop the antiplatelet therapy. So the fracture was managed conservatively at that point.
So if I like to comment on your interesting case, I like this case with its comorbidities, and there's a lot of other involving other systems. You have pneumothorax, you have hematoma, you have pericardial effusion, but sometimes it's difficult to decide whether this is type 1 MI or maybe it could be type 2, maybe because of hypotension, and he had underlying coronary disease, and then he passed into MI. The other thing is dealing with the coronaries. Maybe I don't know if you suspected that the gunshot had passed beside, or I mean, what is the cause of the injury to the intima and the endothelium? Because in this case, the artery is friable, and so even putting a stent, the artery by itself it may rupture because these vessels are now very friable. And we have seen in the Heart Institute in Cairo a lot of cases with VSCD, VSCR, or VS ventricular rupture due to stab wounds and due to gunshots, and the patients were lucky enough that they survived and they came to us. And some of them, I remember, they came with the knife inside the heart, so we did not remove the knife until inside the OR. So I congratulate you for the case. It's you're so lucky that everything went perfect at the end, and the art is very well fixed. But of course, any mishappen could occur. I mean, this rupture of the whole artery or stent thrombosis that may happen because of the. I'm sure you couldn't give him full anticoagulation as usual, but the outcome was finally very well accepted.
Thank you so much. And that's why we have the surgery as a backup, because we know at any point something might go wrong.
Yes.
So we wanted to have all the opportunity to save this young guy alive.
Yes.
Congratulations, Sarah. Such a good case this is. I have a few questions. How long ago he came to the hospital, and the troponin peak was within 8 hours? Because you, so that's a little bit surprising that troponin peaked even before you took the patient for intervention, because if de novo lesion within 8 hours, like peak of troponin 200, usually you will expect the peak to be like, few days later rather than so fast, one thing. The second is 200 after troponin. And most of the time it can be from cardiac contusion, most likely then, unless the infarct is complete from the LAD. So that's a little bit surprising, but of course this is this was a good case. So do you have any comment on that? How come the troponin peaked before, or do you have any level after the procedure?
We think initially all the troponin, which was mild, is smeared for cardiac contusion. But when it went back to 200, we guess this territory completely infarcted, because subsequent echoes showed the apex actually was aneurysmal. So probably he already had infarction by the time we took him, which was like within 6-8 hours. We see a lot of STEMIs, like they don't completely infarct or their troponin doesn't peak, and they will be like 12-hour presentation from the onset of the chest pain. But his situation was really very surprising.
And did you ever give a thought about that if there is any need of subsequent surgery, you will use Cangalore or some other mediator, for the antiplatelet strategy?
This is always in back of our mind. In case he need any surgery, probably we're going to start him on IV Cangalore and just bridge him through the surgery and then put him back on the Brilinta.
Couple of questions and thoughts. One is I congratulate you. I think this having an open mind to look at these patients is important, because over my years in a trauma center, we've seen all kinds of things, from a patient having an infarct after the trauma surgeon took him to the OR to stop bleeding and occluded the sewed off the LAD, and you can go down the list of things that happen. A couple of things in the US that I've seen is trauma causing it, and it happens in football injuries, so-called spear injuries, where young people are hit in the chest, but the helmet direct hit. And I've seen a couple of infarcts that way. And I don't think you ever know what's there until you look. And so I congratulate you. I think that was the right way to do it. I have one question. After the procedure, did you re-IVUS the vessel after the stent? Because it looks like it may be slightly under inflated.
No, we did not IVUS after that. We IVUS only before.
Right.
Actually, I was actually pleasantly surprised by the quality of your echo images. Because, if you think about it, you have a traumatic traumatic hemothorax, maybe hemopneumothorax on the left side. And still you have fantastic apical images. And that's actually pleasantly surprising.
But the issue, we don't have the peristernal long axis because the bandage on the left. So most of the image has to be like apical views.
Yeah, I was surprised because, apical views through that left lung, I would have thought that with, pneumothorax and a chest tube on that side, the image quality would be a lot worse. But, that image quality was pleasantly surprising.
Okay.
Yeah. In terms of mechanism of injury, I have a little bit of insight into this from the perspective of ballistic missile injuries. And a lot of this is related to cavitation related injury. In other words, it's not really in the track of the bullet per se, but it is the area surrounding the track of the bullet. And that can cause and which goes to the point that Kusum brought up as well, that can not only cause injury to the blood vessel, causing intramural hematoma, dissection, myocardial infarction, but it can also cause direct injury to the myocardium itself, and some of that can be manifest in different ways as well. So there's probably a mixture of things going on. The vessel injury is part of it, but there's probably direct myocardial injury as well. From the cavitation injury that probably is playing into this as well. So it's probably a multifactorial situation. But again, you guys should be congratulated for thinking broadly and getting this patient to the OR in a prompt manner.
I agree, Gautam, totally with you that troponin elevation of 200 in 6 hours, unless until you had a closed vessel and reperfused, it's unlikely to diffuse from, especially the LAD, diffuse from the myocardium, which is getting blood. And that's how actually the troponin appears in the blood. So it has to take at least a good 24 hours for your peak to be 200 or that high, especially when you found the artery is totally occluded. So there has to be a mixture of a contusion and infarction.
Okay, if there are no further questions from our panelists, I think we picked up the audience questions as well. Thank you so much, Dr. Doleeb. That is a very enlightening presentation. Let us go ahead and move on to our next presenter, Dr. Valery Effoe, and I will have Dr. Sachdeva introduce him.
So Valery is our second-year cardiology fellow, and he has interest in interventional cardiologists. He has done extremely well, so I welcome Valery to come and present his case.
Valery, you're still on mute.
Oh, sorry. Thank you, Dr. Sachdeva, Dr. Kumar, and all the panelists. Good morning or good afternoon, wherever you find yourself. I'm going to share my screen here a few minutes. Can everyone see my screen?
Yes.
Okay, perfect. So I'm going to take our minds away from the coronaries and talk about something different. I'm going to present a case of an acute submassive PE that for a patient that we had at our healthcare facility. I have no disclosures for this talk. And this was a 61-year-old female who had presented to the emergency room coming directly from her primary care doctor's office, because at the time she went to her doctor's office, her O2 sat was 77%. So they sent her directly to the ED. And when she came to the ED, the main complaint was that she was having trouble breathing. And in the past, this is a patient who 3 years prior to this incident had a DVT, which ended up with her developing a PE. She also had chronic kidney disease, and with a host of other comorbidities, hypertension, pulmonary hypertension, heart failure with preserved ejection fraction, as well as obstructive sleep apnea. Now, since her PE, which happened 3 years prior, she had been on anticoagulation until 3 weeks prior to presenting to the ED when the anticoagulant was stopped, because there wasn't really any indication for lifelong anticoagulation in the patient, and she had also developed some degree of hematuria. So on exam, her blood pressure was 144/94, heart rate was 81, her respiratory cycle was 21. She was morbidly obese with a BMI of around 47. And her oxygen saturation on 3 liters of oxygen was right around 96%. But then after it kind of deteriorated to 88%, even on 5 liters of oxygen. She was in mild respiratory distress with some distended jugular veins and bilateral 2+ beating edema. So the decision was made to, so we initially got some labs. Creatinine was 1.9 on admission with a estimated GFR of 33. Troponin was just slightly elevated, indicating some degree of myocardial injury. And her BNP was elevated at 932 with some moderate anemia. On arterial blood gas, arterial partial pressure of oxygen was 56, so that was kind of low. So the decision was made to obtain a chest, a CT PE protocol because of high suspicion for PE in this patient. And it showed a saddle pulmonary embolus, which you can see on this first image, where you have the yellow arrow. So you see the saddle PE with the clot extending more to the left pulmonary artery trunk than on the right side. And there was some degree of right ventricular dysfunction with an estimated RV to LV ratio of about 2. So the RV was significantly dilated, as you can see on that image, on the CT image. And also on echocardiogram, her right ventricle was dilated and there was some degree of right ventricular hypokinesis. Her LV ejection fraction was normal. So overall, we have this patient who is presenting with an acute submassive PE, hemodynamically stable, but has some elevated cardiac biomarkers, who has an intermediate risk PE. And she also had some intermediate risk of bleeding with an estimated Rider score of 4, which translates into a 3% risk of clinically significant bleeding in case you were to go the route of anticoagulation. And so the decision was made to pursue a catheter-directed embolectomy over a catheter-directed lysis, given that the patient had some significant risk of bleeding. And for catheter-directed endovascular therapies for pulmonary embolism, traditionally, this has always been done with the guidance of pulmonary angiography with the use of IV contrast. And so for patients who present with acute submassive or massive PE, who in addition to that have an associated kidney injury, either an acute kidney insult or maybe a chronic kidney disease, they already go through CT PA, which gives them some amount of contrast, about 100 cc's of contrast. And so proceeding with catheter-directed therapy with additional use of IV contrast during pulmonary angiography increases the risk of developing contrast-induced acute kidney injury, which can put some of these patients into significant risk of morbidity and mortality as well. So our approach was a right femoral approach. We introduced an intravascular ultrasound over a J-tip wire, and the intravascular ultrasound was really to help us to kind of roadmap the area where the clot is, kind of help us guide the aspiration. As you can see on the first image, that's the tip of the intravascular ultrasound where you see the yellow arrow. That's at the level of the pulmonary artery bifurcation, you know, where you have the bifurcation between the left and the right PA. And the image in the middle is the IVUS image, the inside the vessel where you see the clot. So this is some degree of the clot at the level of the pulmonary artery bifurcation. And then we then proceeded, once we identified the level of clot using the intravascular ultrasound, we then proceeded to a manual aspiration using a 20 French 95 centimeter Inari flow triver aspiration system. And we later on performed an IVUS post manual aspiration just to confirm that, you know, we got a good amount of the clot out. After the PA bifurcation, we then went into the right PA. As you can see on the first image, the IVUS catheter goes further from the previous position into the right PA. And there in the middle, you can see the image in the right PA with the amount of clot within the vessel. And the image to the extreme right is the post-embolectomy IVUS image showing the amount of clot that has been aspirated from the right PA. And later on, we went over to the left pulmonary artery with the IVUS. Again, the image in the middle shows the degree of clot in the left PA, and the image to the right shows the post-embolectomy image. So we weren't able to completely, remove the clot that was in the left PA. And I guess part of it was chronic clot that she developed 3 years ago when she had a pulmonary embolism. And so this is what, from the PA bifurcation, left and right PA, this is the total amount of clot that was removed during the entire procedure. And the syringe you see there, that's a 3 cc syringe. Just kind of gives you a comparison of what the amount of clot that was taken out is. So post-procedure, we noticed a modest reduction in her pulmonary artery, mean pulmonary artery pressure. Remember, this is a patient who already had some pulmonary hypertension. Her starting the procedure, her mean PA was 53. And at the end of the procedure, it had dropped to 49. She did report some improvement in her breathing, and her oxygen saturation actually improved from 88%. Before we started the procedure, she was 88% on 5 liters of oxygen, and she had improved to 96% on 2 liters of supplemental oxygen. And so the whole premise of going for the IVUS only catheter-directed approach was the fact that this patient already had a chronic kidney injury and had already received IV contrast during the chest CT with P protocol. And giving her additional contrast during pulmonary angiography during the procedure was going to put her at further risk of renal deterioration. And so in using IVUS, you avoid using that second load of contrast and actually reduce the risk of this patient developing a contrast-induced acute kidney injury, or making it worse, because she actually developed a contrast-induced acute kidney injury from the contrast she received during CT PE. So, but when seen after six weeks after she was discharged from the hospital, her renal function had come back to her baseline level. So, in patients who present to the emergency room with an acute PE, either an acute submassive or an acute massive PE, about 5 to 15% of them are going to have some form of renal dysfunction. And so, using the use of IV contrast, either for a diagnostic, either for diagnostic purposes using the CTPE protocol, or for management using a catheter-directed approach, this puts the patient at a significant risk of morbidity and mortality. And so we think doing a percutaneous approach, percutaneous catheter-directed approach, is feasible in a certain group of patients, those with PE, either submassive P or massive P, and who also have some degree of kidney dysfunction, and who are at an increased risk of bleeding. Remember, she had a Rider score of 3 or 4, which was about a 3% risk of clinically significant bleeding. And by using an IVUS-only approach and reducing that second load of contrast, we think this can actually help to reduce, not only reduce the incidence of contrast-induced acute kidney injury, but also actually help to preserve some degree of renal dysfunction. And I would like to thank Drs. Sachdeva and Drs. Kumar, who worked on this case with me, or who I worked on this case with them, actually. Thank you. I'll take any questions.
So this was a good, very good case. First of all, when you do the PE thrombectomy, if you have CTA, you don't need to do pulmonary angiogram at that point of time, unless you are not sure about whether you have completed the thrombectomy or not. So you can just go blindly if you have CTA, and then you can do the thrombectomy, mechanical, or whatever way you want to do it. So, and second of all, did you do entire right-sided hemodynamics to make sure patient was not in the RV shock? This is just for the further management of the patient, like, you know, what else the patient needs support, like additional treatment. Did you do that?
Yes, we did entire right side hemodynamics. The cardiac index was I can't remember the exact number, but it was above 2. Her RA, mean RA before the procedure was 22. It dropped to about 17 post-procedure. RV systolic was about 83 prior and dropped down to 76 post-procedure. So she had some modest reductions in the mean pressures, but she wasn't in any shock. She wasn't in any form of shock.
So, Dr. Valery, it's quite very interesting in that case with submassive. For those with massive embolism, maybe you don't have time to cure them, but those with submassive,
yes.
The idea of using embolectomy mechanical is since ever. I mean, I've been working with Alan Krebi in the 90s, and he was also trying some devices for that. But until now, there is no clear cut of whether this should be the treatment, the default treatment, because it is still with unpredictable results, and there have been many innovations, many devices for that. But still, we wait. Maybe you tell us with your experience. Do you think this was a friendly use, and it could be you could rely on that? Actually, the medicine is waiting for something like these devices to treat cases with submassive embolism. The other point is it is not only the embolectomy, but usually the body or the vessels are in a state of, it's like acute coronary syndrome, a state of hypercoagulability, and maybe a thrombus begets the thrombus. And so whenever you take some thrombi, other thrombi may develop. And so these are the two challenges. Do you think this could be recommended and should be in the cath lab, and to be used such devices for embolism in the future?
So we think that, you know, the use of IVOS, the use of an IVOS only approach in patients, in managing patients with acute submassive PE, it could have its role in a certain group of patients, maybe not in all patients who present with an acute submassive PE, but in those patients who have this presentation with associated renal dysfunction, because the whole idea was to reduce the amount of contrast that we give to the patient so that the patient doesn't tip over there's no further deterioration in the patient's renal function. And to go back to Dr. Lata's question, point about, you know, doing the procedure blindly, using the images from the CTPA you got before, that is absolutely possible. It's done in some centers, but the unique thing about the IVOS is you do pre and post images, so you actually have confirmation that, you know, something has been taken out, that you've taken out the clot where it was.
Yeah. So I have additional question. Did you leave any local thrombic TPA or something dripping post-procedure? Because it looks like there is a lot of thrombus burden. And acutely you have removed a significant amount of thrombus, but all these smaller clots, the clot burden matters a lot in later on the PEA. So did you leave any local catheter for overnight, dripping there, or no?
No, we did not.
And why did you thought it was not necessary?
I think, and I'll also let Dr. Sachdeva and Dr. Kumar jump in. I think because we use IVOS to actually confirm pre and post that we did the road mapping with the IVOS, and we went to the same spot, did the manual aspiration, and did a post IVOS confirmation that a clot has been taken out. I think, given that we saw that in the PA bifurcation and in the right PA, we actually removed the great majority of the clot. The only problem was with the left PA, which we think part of it was chronic from her PA that she had 3 years ago. I think if you can confirm that, you know, the majority of the clot has been taken out, I don't think there is a reason to leave the catheter in there for overnight drain?
So these are all interesting questions. Giving lytics, amount of lytics which you're going to use versus just doing embolectomy alone. So this case which Valery presented is unique. We wanted to decrease the amount of contrast while doing the procedure and use IVUS as standalone as the only guidance modality to locate where exactly the clot is and where we're going to park our Inari catheter to apply suction. So you can blindly go and park your catheter and do suction, and you can keep on doing multiple suctions. Then you run into another issue of how much blood you have sucked out. And Inari, for that particular reason, has come up with a device which is a filter, so you can filter out the clot and give the blood back. And Penumbra actually has gone through the same sort of modification because, in one suction, you suck out about 60 ml of blood. So if you apply 5 suctions to one side and 5 to the other, you can actually see how much blood you're going to actually lose. So that's another, with the person whose hemoglobin is already 10. Secondly, she was a high bleeding risk. So giving TPA was, of a concern. So not only just bleeding, concealed bleeding, she is also at the risk of intracranial bleeding with TPA. Though the risk of intracranial bleeding is much lower than a full dose of TPA, but it is there. So if you sort of look at the meta-analyses of the trials which have been done, the risk of intracranial bleeding is somewhere in the range of 1 to 3% with full dose TPA. And it drops to about 0.5 to maybe about 1% with the catheter directed, because you are giving smaller dose over extended period of time. But the risk is there. And we have seen that if you use TPA in an elderly population, that risk is there. If this was a younger patient, that risk is sort of much lower compared to the elderly population. So that's the reasoning behind. And the second question is, which Dr. Lata asked, is about dripping TPA after the clot has been sucked out. So what we have noticed is, you want enough clot to be sucked out. I don't think there is a modality that you can clean up the clot, all the clot, completely, whether you use TPA, whether you use Inari, whether you use Penumbra. I think it's enough amount of clot you want to take to change the acute hemodynamics. So you want your PA pressure to come down when you suck out this clot. You don't want to really be able to sort of clearly or clear the whole of the clot which is there, because you also can risk perforating the artery when you become very aggressive. And when there is a chronic clot, it becomes more difficult to suck out. On the other hand, you can deploy discs, but when you deploy disc, then you can risk perforation. But IVUS is also important in that scenario. Is you can actually open up the discs to the size of the artery. Okay, so you can know if you're where you are and what is the size of the pulmonary artery before you actually open up your discs. So I think IVUS is quite helpful in these cases, and we have been using more and more IVUS. And this is the 035 IVUS. We are not using that 014 or 0118 IVUS. We are using 035 IVUS. So the field of view is much larger.
Thank you very much, Dr. Sachdeva there. I also wanted to have Dr. Kumar bring up some of the panel questions. Arun, you want to go ahead?
Yep, thank you, Gautam. Just one question was, is there an outcome difference between Inari catheter versus ECOS? And so maybe to the other panelists who do some PE work and peripheral work, any thoughts or preferences between one versus the other?
So to the best of my knowledge, there's actually been no head-to-head comparison between the ecosystem and the Inari system. Now, mechanistically speaking, the two are two different systems. One is a catheter-directed sonothrombolysis system, the ecosystem. Now we can have a separate argument and discussion about the sono, whether it actually does anything or doesn't really do anything. That's a separate discussion. The other one, Inari, is a mechanical thrombectomy catheter, which is a mechanical aspiration catheter that does not involve lytics. That's one difference. The second important difference is that the ecosystem is generally a 6 French system, whereas the Inari system, if you use a T20 catheter, it's a 20 French system. If you use a T24 catheter, it's a 24 French system. And this is a non-steerable large catheter that can sometimes be a little difficult to drive from the leg all the way up through the PA bifurcation into the target vessel. However, it is still possible. So your access size in your sheath size in the groin is also going to be much larger. So therefore your management strategies for that is also different. Yes, I agree with you. Angiography is generally not implemented for ECOS. I think that was one of the questions that was in the panel question as well. That does not require contrast injection. However, when you're, on the other hand, there is a risk of lytics. With lytics, there is a risk of bleeding, which again, a mechanical aspiration system is supposed to avoid. Now, we're not necessarily, for those of us who do PU work, we're not necessarily advocating for a one-size-fits-all approach. But we're advocating for an approach where there's a different degree of different devices can be used for different patients based on the balancing the risk of bleeding, the location and type of thrombus, the chronicity of thrombus. It is highly unlikely that lytics are going to do much for a very chronic thrombus, which is fibrosed, whereas you may be able to get it with the aid of discs. The other thing about the chronicity of thrombus is to remember that these thrombi might have been in the lung for 24 hours or 48 hours or 72 hours, but they probably came from the leg where they have probably been there for several weeks. And even if they're not chronic in the lung, they were chronic in the legs. So that's another thing to remember when it comes to the chronicity part of it. In terms of the IVES, I think it enables us to do a number of different things. It enables us to size the vessel so that we know how far we can advance the catheter. It enables disc sizing if you need it. It enables you, like Valery nicely showed, it enables us to ascertain what is the chronicity of the thrombus. If it is wall adherent, bright thrombus, it is probably fibrosed thrombus that is adherent to the wall. If it is mobile, relatively round thrombus, ovoid thrombus floating around on the inside of the vessel, that is mobile thrombus. You're more likely to be able to get it without the need for discs. The vessel sizing is also important. You can also tell the type of flow around the thrombus. If you, and again, as Dr. Sachdeva mentioned, this is the 035 IVES system, where you can actually see more of the vessel and the architecture of the vessel. The 014 IVES has too small a field of view for those of you who are thinking about intervening on these pulmonary thrombi.
And what? Thank you. Can I just ask one follow-up question for Gautam or the others on the panel? What is the length of chronicity that you want to do these procedures within, either with Inari or ECOS? At what point, within what time frame do you want to jump on these? At what point do you think it's a little too chronic to get benefit?
So,
go ahead.
Okay, so as far as the procedure is concerned, when the patient presents acutely, we actually take them to the lab within 24 hours. I think you have a better chance of aspirating the clot if you can sort of see the history is more acute. If it becomes more chronic, if clot has been there for a week or so, it becomes very difficult to actually aspirate the clot also, because some of that clot may be adherent to the wall. And so is the case when the clot is chronic, it becomes even very difficult to dissolve that clot with the TPA. And there may be a need to actually leave the TPA for a much longer period of time also. So I would say that within 24 hours, and I think the success of any procedure also depends upon how acute the presentation is.
And do you recommend the routine use of new oral anticoagulants afterwards, or the classic anticoagulants? What is the adjunctive medical therapy with thrombus aspiration?
So if we did a inari embolectomy this afternoon, and we will put them on a DOAC this evening, and then they can go home. They can get an echo in the morning and can be discharged in the morning. So that's the way we have actually sort of operated in our hospital with these embolectomies.
But the loading dose of the new oral anticoagulants, or the maintenance, I mean, you give as if it's acute pulmonary embolism, and you give the high dose, I mean, like rivaroxaban, 50 milligrams twice daily, or you just give the maintenance for them? You give the loading dose, the high dose of the new oral, or you give the maintenance?
So we will, if we are going to go with the Xarelto, we will give them a 20 milligram dose, and then they will be discharged on the same dose.
Okay.
And for Eliquis, you can keep on the loading dose and then bring it down to maintenance dose.
Okay.
Dr. Kusum, Lata, you had a question, and I think that'll be probably the last question.
No, I had pretty much the same thing, that, you know, within 24 hours, or if the patient is getting worse, within 48 hours, you are calculating the score, or patient is hypertensive, tachycardic. And then the second thing is managing hemodynamics is very important. All these patients are also volume overloaded. So for the fellows, make sure that you generously diurese the patient, because there is always worry that patient has RV shock, and so don't diurese the patient. On the contrary, if you diurese these patients very gently till the point, like, you know, monitoring the blood pressure not going into the like volume dependent or so, hypovolemic, then these patients get significantly better. So make sure that generously, because RA pressure of 17, there is definitely some volume overload also. So generously diuresing this patient and concomitant aggressive anticoagulation helps a lot.
Okay, perfect. Thank you so much again, Dr. Effoe, for your presentation. My next speaker is going to be from Turkey, who is Dr. I am hoping that I'm pronouncing this correctly, Dr. Karos. Is that correct?
Yeah, I'm here. Hi.
Hello, welcome. And he's an interventional cardiologist with 8 years of experience and has done significant percutaneous coronary interventions, EP, and device implantations. He is also very interested in heart failure and is going to show us today his case. Please, welcome.
Hi. Can you see my screen?
Yes, absolutely.
PowerPoint presentation, can you see?
Yes.
Dear Chairman, dear moderators, dear colleagues, good morning, good afternoon, and good evening. It's my great honor and privilege to participate in this meeting and have the opportunity to present our case. And it's also my special honor to present a case in the last 4 C3 meetings. I would like to thank the scientific committee. Our case is about, excuse me, our case is about a successful intervention to a severe subclavian lesion, which causes coronary steal through a Lima LAD bypass graft. Here is our patient. Our patient was a 68 years old male. He underwent coronary artery bypass grafting in 2013. He presented with stable angina pectoris and ischemia was detected in anterior wall in myocardial perfusion scintigraphy. And the patient was scheduled for coronary angiography in another hospital. The patient underwent coronary angiography in another hospital, and here are the angiographic views of the patient. The LAD was totally occluded just after the first diagonal, and as you see here on the right, the stroke was normal. The RCA was again totally occluded, and the aorta and RCA graft couldn't be displayed. And as you see here on the right, 90% stenosis was detected in the proximal part of the subclavian artery. The Lima LAD graft was patent, and the ischemia in the anterior wall was probably due to the severe lesion in the proximal part of the subclavian artery. So the patient was scheduled for intervention to subclavian artery in our hospital. A 6 French Judkins right guiding catheter was advanced through the right femoral artery, and additional 6 French Judkins right diagnostic catheter was advanced through brachial artery in order to display post-traumatic distal part of subclavian artery. Here on the right, we can see that we advanced the balloon through the guiding catheter, which was inserted from the right femoral artery, and on the top we can see the diagnostic catheter, which was inserted from the left brachial artery. Then a 540 millimeter paclitaxel eluting balloon was advanced through 6 French Judkins right guiding catheter and inflated at 10 atmosphere. And on the right, we can see the blood flow after inflation of the balloon. The balloon inflation enabled advancement of the stent, and a 925 millimeter balloon expandable stent was deployed in the proximal part of the subclavian artery with some protrusion into the arcus aorta. We can see here on the right. The lesion was fixed. There was a satisfying appearance. The stent was minimally protruded into the arcus aorta, and here on the right we can see the final appearance. If there is a severe subclavian stenosis, there are 3 possible clinical scenarios. The first is a subclavian steal syndrome, when the blood is diverted from the vertebral arteries with symptoms involving the posterior cerebral circulation, such as dizziness, presyncope, and syncope. Acute or chronic ischemia of the upper extremity can be possible when the subclavian artery stenosis is the cause of thromboembolism, or when it's obstructed with disabling exertional discomfort. And such as in our case, a coronary syndrome can also develop. It develops when the blood is diverted from an arterial mammary graft, which supplies the coronary left system in favor of the left upper extremity. Especially this happens when the stenosis is in the proximal part of the subclavian stenosis, such as in our case. Use of multiple projections is of great importance. Anterior, posterior, and ipsilateral oblique projections have to be taken. And the origin of the artery, subclavian artery, and its correlations with the vertebral and internal mammary arteries should be investigated. Manual pullback with a diagnostic catheter from distal to proximal subclavian artery to detect pressure gradient is also important. A 25 or 30 mmHg pressure gradient is usually enough for detecting significant stenosis. In our case, we didn't need that because there was a ischemia in the myocardial perfusion scintigraphy, and this was enough for us. Either femoral or brachial access can be used in subclavian interventions, but using brachial or radial approach is mandatory to cross the occlusion segment at the ostial or proximal part of subclavian artery, because the guides and wires engaged in the aortic arc are usually unable to provide enough backup and penetrating force. Sometimes, if there's an angle takeoff, we can need a sidewinder or Vitek guide. Unlike the major arteries, the origin of the subclavian artery is more fragile, and we should be cautious not to overdilate this vessel, which can cause catastrophic results, such as rupture. We should maintain the stent 3 or 4 millimeter out to the ostium into aorta, as we have done in our case, to assure the full coverage of the ostium. And we should be sure that the important vessels such as internal mammary artery and vertebral arteries are not compromised. When we use a balloon expandable stent, it is sufficient to have a slightly inferior, it's sufficient to have a diameter with slightly inferior to the vessel size, because most balloon expandable stents can be expanded to correct size with post-dilatation balloons and with minimal shortening. But when we use a self-expandable stent, we should select one with a diameter equal or slightly superior to that of vessel. And our take-home messages are subclavian stenosis should also be investigated when we detect an ischemia in the anterior myocardium in patients with Lima LAD anastomosis. Balloon angioplasty or stenting can be the first option before surgery. A coronary ischemia, in fact, can be treated with a non-coronary intervention, and to be familiar with the peripheral interventions is of great importance. Thank you for your attention.
Excellent presentation. I had a question for you, and probably Samir can comment on it as well. What were your thoughts about left subclavian approach for stenting of the subclavian stenosis?
If the operator could comment first, and then I'll tell you our experience.
Dr. Cargos, I don't know if you heard the question.
No,
left subclavian approach. What is your thoughts about left radial approach for stenting of subclavian?
We use brachial and femoral approach. To be honest, it was my first intervention to subclavian artery, and we use brachial and femoral approach. In fact, actually, you can use one approach if you use a larger sheet, a 7 French or 8 French sheet or guide. You can use one access, and you can perform both contrast injection and both advancing the stent or balloon with one route. But here we used 2 access, one femoral and one brachial. But I have never seen a radial access for subclavian intervention.
Yeah, so there has been a fair size experience stenting subclavians from radial access. John Coppola and his group from New York actually, were one of the first in the US to kind of start using it. The Europeans had been using it prior to that. And as long as you have a palpable pulse, even if it's very feeble, with ultrasound you can get access. The benefits obviously in the hemostasis part of it. Obviously brachial would work, but hemostasis and complications are significantly more than radial. But yeah, I think left radial approach in this case would have been very good. You can use a variety of sheets which accommodate the peripheral stents. Nowadays there's more available than previous. Terumo has always had hydrophilic sheets which are 7 French and expandable stents.
Thank you.
So I've performed from the left radial approach and the subclavian intervention. I did it, and most of the time Dr. Pancholy says the access is the issue, but you can deal with that with the ultrasound. What I found it's difficult to, if we have like 9 or 10 millimeter stent placement, it's difficult. But what is good is if you can cross it, like I did the CTO of left subclavian and I crossed from the left radial. But when you cross it, and then it gets a little bit challenging to, like sometimes if there is a tortuous vessel, challenging to get the balloon, larger size balloons or so. But good point is once you cross it, you can go to the femoral and you have already made the channel. You can easily cross from there and change everything all from the femoral. And then the second thing is a good point to have a catheter or guide from the distal part of the subclavian or proximal from the arm side to look at that side, how our stent is covering. And so that's really a good point, because most of the operator, they will just do from the aortic side the picture and they will just see the contrast washout. I personally feel that that's a little bit inadequate picture for the distal side. My second question to you is, did you use any sheath from the aortic side, or just how did you place the stent, or just you just went blindly? Because I don't see any shuttle sheath or something. Did you use something?
Thank you for the question. We didn't use a long sheet. We didn't use a destination. We used ordinary short sheets, and we used guiding catheters to advance the stent. We engaged the ostium of the supraluminal artery with a 6-branch Judkins Wright guiding catheter and advanced the stent through it.
So
we didn't use a long sheet.
What was the size of this stent? I'm sorry, I think, was it compatible with the 6-French guiding catheter?
Yeah, 925.
Yeah, because the internal lumen of the 6-French guiding catheter, it's really like, no, but of course you did the procedure to go through that, the first, and then the, because that's really important. So it was very easy manipulation through the guiding catheter, going that is 9.0 stent.
Yeah, we could manage. You are right. It can be complicated, but we were able to engage the ostium and we were able to advance the stent through the guiding catheter. We didn't use a destination catheter.
So Ahmed, I'd like to raise 2 points with you. One of them is this. I mean, it's ischemia and post-cabbage. I'm sure they didn't know that this patient is, or this pathology did not happen before the bypass graft. So the other thing is, this is a physiology disease. I mean, did you perform some physiology to know how much the ischemia? Did you need to pass IFR or FFR to the Lima to see? I mean, this would be interesting to us to see the ischemia after you put the stent. Did the ischemia vanish, or there was residual ischemia or not? The other thing is dealing with the subclavian. Sometimes there is some small branches appearing from the early part of subclavian. So maybe we need to know if there is any risk of having stroke or not, or if when you put the direct stent, of course, on that part, any precautions for that.
Thank you. Regarding your first question, unfortunately, we didn't perform perfusional scintigraphy after the procedure. The patient was free of the symptoms, and we didn't need to quantify the ischemia. It will be better to perform a myocardial perfusion scintigraphy after the procedure, after the deployment of the stent. And regarding your second question, we didn't need to do something to prevent the vertebral artery, because it was quite far from the ostium of the vertebral artery. It is recommended to prevent the ostium of the vertebral artery if it is also included in the subclavian lesion. In our case, we didn't need to wire or put a distal protection device, and we didn't face with a complication.
But I mean, did you do physiology? Yes, sorry. I mean, did you do the FFR, not the scintigraphy? I mean, did you need to use FFR to measure if there is ischemia, and did it appear or not?
No, we didn't. No, we didn't use FFR.
George?
Yes, I want to challenge this slightly. I think this is ischemia caused by a subclavian stenosis, but I'm not sure it's steel. I think you have to have a patent LAD to have with stenosis to have a steal. And when I looked at your angiograms, I did not see refluxing flow in the IMA. So I think you had massive ischemia because he's living off his IMA, but I don't think it was a true steal.
I agree with you. At first, it was a strange definition for me, coronary steal. But when I look at the literature and when I look at the interventional books, this is called coronary steal. And the statements I used here, I take them from an interventional book, and this case is called coronary steal. This is interesting. But I think in the same way as you at first.
I'd like to just make a comment to follow up on something Dr. Lata said. I know there's some fellows who are the attendees right now, or maybe young interventionalists. I think it's very important to have a good familiarity of what goes through each size sheath versus what goes through each size guide. So what might go through a 6 French sheath may require an 8 French coronary guide. And as interventionalists do more peripheral work, have to take out impellas and doing TAVRs, you're going to want to know what equipment you have at your center and what size sheath you need to be able to deliver specific size balloons, stents, and covered stents. So you really want to be familiar with that information.
Yeah, thank you.
Okay, that's perfect. So thank you so much again. That was a great presentation. Let us move on to our next presenter. And I would like to invite Dr. Paneerselvam Arun Kumar, who is practicing as an interventional cardiologist in Royal Care and Eugene Clinic in India. He's been involved in clinical research and coronary and structural interventions. Dr. Arun Kumar, welcome again to C3. I know we've had the privilege of meeting every year over the past several years.
Thank you, sir. Thank you.
Welcome back. It's good to see you virtually again, although we missed each other this year thanks to COVID-19.
Yeah. Hope you're doing good. Thank you, sir.
Good. Please tell us about your case.
Yeah. Good morning, everyone. At the onset, I would like to thank the chairpersons and the C3 team for having given me this opportunity. This is a case of time heals cath lab nightmare. This was a 69-year-old gentleman who had no risk factors for coronary artery disease. He was shopping for his son's wedding. At that time, he developed anginal pain and he came to the hospital. And we did an electrocardiogram which showed ST elevation in anterior leads. So he was loaded with ticagrelor 180 milligram and we shifted him to the cath lab. The window period was 2 hours. And he also happened to be the own brother of our in-house neurosurgeon. So he is the brother of our neurosurgeon who does all this hybrid work. So he was standing behind me in the cath lab. That's how we started with the procedure. We went through the right radial approach. You can see there was a proximal LAD total occlusion. The circumflex and the RCA was normal. So we took a Sion wire and we crossed the lesion. The lesion was pre-dilated with a 2x10 compliant balloon and the flow was established. So then we stented it with a 3.5 into 28 millimeter Zients prime stent. You can see the flow was relatively good. Then we did a stent boost imaging. You can see there was a small indentation in the proximal part of the stent. It looked slightly underexpanded. So I thought I will post dilate the stent with a balloon. So I used a 3.5 into 10 NC balloon and post dilated it at 10 atmospheres. So after post dilation, you can see there was some haziness within the stented segment. So it looked like whether there was some plaque prolapse or was some thrombus was there at the dilated segment. So I was not sure whether it is a thrombus. So I thought I will post dilate it again at a low atmosphere with the same balloon. So I took the same balloon 3.5 into 10 and dilated it at 4 atmosphere so that I thought it will adhere the thrombus to the vessel wall. So that's how the problem started. So you can see once the post dilation was done, the flow started decreasing, and now he was becoming a bit unstable and he was started getting chest pain. You can see the flow was almost reduced to TIMI1 and there was extensive thrombus formation. So since there was a lot of thrombus, I thought I will do a thrombosection. So I took a thrombosection catheter. It was a thrombustor catheter, went down. And during that procedure, he went for a cardiac arrest and he was intubated and he was totally crashing. And we started him on noradrenaline and dopamine. He was getting recurrent VT and VF. And we had to shock him almost 10 to 12 times to keep him alive. So you can see there was hardly any flow within the stented segment, and there was a lot of thrombus proximal also. Still there was no flow. This is how I was feeling at that time. In front of me, the patient was crushing, and the neurosurgeon, who is his brother, was standing behind him, and the patient's son was standing outside, who is getting married next week. So the pressure on me was even more to bring him out. So we were not sure how to bring him out. So this is what we were trying. So we gave him a bolus of intracoronary tirofiban. We gave intracoronary nitroglycerin, nicorandil, sodium nitroprusside. We gave 5 million units of streptokinase and a very low dose of intracoronary adrenaline through a microcatheter. And despite of all these efforts, you can see there is hardly any flow which could be established within the stented segment. You can see there was no flow within the coronary at all. So we were in a dilemma what to do further, and it was almost 6 hours. We are keeping on repeating all these aliquots of drugs intracoronary, and finally we thought we will at least try to save him, and rather than saving his myocardium, just to keep him alive. After 6 hours of all these procedures and all these maneuvers, he was continued on mechanical ventilatory support. He was put on IABP. He was started on ergotroban infusion. His ACT was around 232. The tirofiban infusion was continued for 24 hours. And his echocardiogram showed an ejection fraction of about 30%. And he was shifted to the intensive care unit for further management. So we continued all these supportive measures. And after 2 days, we were able to extubate him. And he was hemodynamically stable, maintaining stable pressures. And his echocardiogram showed hypokinetic LAD territory, and his ejection fraction was around 40%. And he was discharged after 5 days so that he could attend his son's wedding. So it was a miracle that he survived despite all our efforts. And 6 months later, so we again took him to the cath lab. So this is how the angiogram looks. You can see after all the measures, the flow in the LAD has been established. This is the 6 months angiogram. So the stent was patent and there was very good flow in the LAD, but there was still some haziness proximal to the stented segment. And it looked like there was some amount of vessel disease in the proximal LAD. So we gave him the option of doing a left main to proximal LAD stenting, which he obviously refused. So to conclude, both disasters and miracle can happen unexpectedly in cath lab. The possible causes for this complication include a plaque prolapse, an edge dissection proximally, which could have precipitated the thrombus, or he might have been resistant to the antiplatelet drugs. Once we started him on ergotroban with tirofiban, which was continued for a period of 24 hours, probably the flow was established. So a combination of cocktail and IABP with time had probably established the flow in the LAD. So that's how I was able to take my head out of the tiger's mouth. Thank you for your attention.
Arun Kumar, congratulations on a fantastic case. I mean, this is a total, it's a disastrous case that you have salvaged beautifully. I think the entire panel is in agreement with us, with me on that statement. Now, what was I had 2 questions for you. What was your ACT just before you deployed the first stent? And what was your anticoagulation strategy? Was it unfractionated heparin?
Yeah, it was unfractionated heparin, 100 units per kg body weight. We gave 7,500 units bolus. The ACT was around 232.
So it was a little bit on the lower side. Not terrible,
lower
but
side.
a
Yeah,
little
yeah.
bit on the lower
But
side.
we had started him on tirofiban infusion also. So we tried to keep it around.
Okay. So he was on
So
tirofiban even before the
yeah.
stent.
Once we started noticing the thrombus, we gave a bolus and we started him on tirofiban infusion. The ACT at that time was around 232.
So congratulations, it's such a great case. And I just had kind of a little bit similar case, and I'll tell you a little bit later, but I just want to ask you a couple of things. If you have to redo it again, what do you think you will do a little bit different in this case? And what do you think the mechanism, proposed mechanism, of course, because we don't know what exactly happened in true unless we do intravascular ultrasound, which was very difficult because your patient was unstable. Like theoretically, we come and we talk about doing OCT, IVUS and all this stuff, but we also have to take into consideration when patient is unstable on the table. We cannot do all these investigations at that point of time. But what do you think is the proposed mechanism could have happened?
The problem started when I started post-dilating the vessel.
Yes.
So probably I would have left it at that stage and maybe I would have taken him later to the lab because the flow was good. He was hemodynamically stable. There was a minimum some 5% under expansion of the stent. Maybe I would have left it at that stage itself.
But my second question is, if the patient was stable, what could you opted there? Would you be doing, if you have intravascular ultrasound, of course, that's the best way. But the second best thing is we can put a distal microcatheter, distal to the stent, and then take a picture to see whether there is a microvascular issue distally or there is a problem in the stent or proximal to the stent. I can just presume because maybe during the post-dilatation, the balloon could have slipped proximally and caused a little bit of plaque disruption because you can see the flow was disrupted just proximal to the stent. And there could be some plaque disruption or plaque flap, and that has blocked the flow. I just had a case 4 or 5 weeks ago. I put a drug-eluting stent on that patient, like he had a cabbage. Immediately a month after the cabbage last year, all the blood vessels were occluded. So he came post-cabbage, still his wound was not healed and back to square one. So I stented his LAD and circ. And after 9 months, he came with a chest pain and troponin leak. And he never had any symptoms, 71-year-old guy. I did a cath and he had a very good post-dilated, LAD proximal stent. There was a little bit of curve of the stent, and within the stent, there was a clot. So I thought I'll just pass a wire and it will go. I passed the wire, it didn't go. So we get adventurous, right? So we want to do the IVUS. I tried to pass the IVUS and probably the IVUS disrupted the clot and the clot came back proximal and there was no LAD flow. As soon as that happened, patients started getting tachycardia. So it was Saturday. I knew that now I'm getting into the disaster. So what I did is I was alone. So what will I do? I will put hemodynamic support devices. Now there is no LAD flow. He started getting tachycardic, some chest pain, blood pressure 90, and I'm alone and I'm doing right radial procedure. So the best thing I thought, maybe the proximal disruption or the clot. So what I can do is, even though this is not the best option, I just covered that. I thought, I did the balloon dilatation. Went just proximally and this happened. So there is something proximal. So I put just took a stent of that size and just covered it proximally and I restored the flow. And then of course he got better. So I was just thinking, did you ever thought about if you
Okay, I think, so Dr. Kusum, Lata, I think we lost you there completely for a second. Can you repeat that last statement after did you ever?
No, so did you ever thought about just stenting the proximal part? Because after that, you lost the flow. And if the patient is very unstable, whatever you do, you just have to reverse that. I'm just theoretically talking about.
No, we were thinking of putting a stent in the proximally from left main to LAD, but we were worried because he was surviving because of the circumflex flow. And there was a whole lot of thrombus in that area. Suppose if he stent and his circ closes, then I think that would have been the end of the game. Yeah. So since he was holding, we didn't want to put one more stent in that thrombotic area. Because every time we try to manipulate, he was becoming unstable. The moment we leave him alone, he was a bit stable. So that's why we didn't put a stent.
I have a slightly different hypothesis of what we think is happening here. I think this is an intraprocedural stent thrombosis or IPST. your ACT, while up there, is not quite up there. It's not totally above 250. And this is a rare complication of PCI, but it tends to happen. And obviously, it tends to happen, especially when the patient's son is hanging behind my head. That's obviously a serious concern when the tiger is standing over your shoulder.
Yeah.
I think this is an intra-procedural stent thrombosis that first started off this thing, because even before you post-dilated, there was some haziness within the stent. And that's how these things begin. And, the typical reaction, I would have reacted the same way. In fact, I had a case a few months ago where I did exactly the same thing. I gave a 2B3A, the whole vessel shut down, did thrombus aspiration. Finally, it opened up. We were able to get some flow down the vessel. But again, this is a very difficult scenario. It happens in around 0.1 to 0.2% of all PCIs. It's not very common. But it can be a real problem when it happens. George, did you have anything?
No, I don't have anything specific. I think you worked your way out of it well. I would have suggested maybe IVUSing that stent first before I post-dilated it. That might have given you a little bit better idea of what you were dealing with.
I didn't have any IVUS with me.
This patient was on clopidogrel or on other antiplatelets?
Ticagrelor.
Ticagrelor.
Yeah.
So did you see any cases of ticagrelor resistant patients?
No. Actually, the ticagrelor was given just 10 minutes before the procedure was started. He was shifted directly to the lab. Maybe an IV cangrelor could have been a much better drug in that scenario.
Yeah, because classically this could be just intraprocedural thrombosis. We used to see it maybe 15 years ago when we had only clopidogrel. Now it is much less with the new stents and with the ticagrelor, but still this is intraprocedural thrombosis and it's intractable one. Maybe the loading of ticagrelor was not, it didn't have time to work. So sometimes your heparin is acting and ACT is okay, but the stent also needs something to soothe the platelets. So classically it is like this. And the other thing that it could be as aggressive as, so it is like intractable thrombus formation because the stent is a foreign body and the vessel is reacting with that like to attack the foreign body. It's intraprocedural thrombosis. We have also seen it in some patients. Did you see before patients who are already on anticoagulants but they get thrombosis? There is some blood diseases that may cause thrombosis, although you are giving all the anticoagulants or antiplatelets, but like antiphospholipid syndrome patients, like those with some sorts of blood disease, that SLE, other. So we should investigate that. Maybe I don't know if verify test can be or some other platelet assessment, because the advocate that ticagrelor and pasogrel, they are no resistance for them, but I'm sure there is some patients that you give them full dose of new antiplatelets, but still they get thrombosis. So you should involve some blood assessments, including these things. But
I think
that he survived. Yeah.
I think if going to your angiograms, you after deployment of stent have a little bit of haziness, suggestive that there is a thrombus. Then you go in to occlude the vessel with an NC balloon that causes more stasis and leads to further thrombus formation. And I think this is a sort of a anticoagulation regimen issue in the cath lab, which then I think sort of led to your stent thrombosis on the table. And then you try to bail out once the thrombosis formed there and occluded the vessel. I think at the initial part, when you realize that there is some haziness, I think ACT, getting it up higher would have been beneficial. And, then adding some 2B3A, which you did later, I think helped the scenario. It's you know, it's not unusual that after you did all this stuff and you left the vessel closed and bailed out with just an intra-aortic balloon pump and hemodynamic support with a balloon pump, that later on when you came back, this whole area had sort of, you know, recanalized. So the thrombus, whichever was there, was taken care of the body along with your anticoagulation regimen. So I think the anticoagulation regimen is the key factor which led to the stent thrombosis on the table, which I think you could have used aspiration thrombectomy, you could have used past over the wire balloon or any transit catheter to check what was distally, to check vessel was open, to answer some of the questions, use intravascular ultrasound to answer some of the things which other panelists said. I think all those things would have helped.
Okay, this is excellent. Thank you very much for your great presentation. Again, it's a fantastic salvage again in this case. Thank you very much again, Arun Kumar. Let me now have the pleasure of introducing one of my fellows, Dr. Leah Raj. She is actually a graduate from Emory University School of Medicine and left us briefly to do residency and fellowship elsewhere, and finally returned back to, you know, finally saw the error of her ways and returned back to Emory for interventional cardiology fellowship. You know, we won't hold it against her. Leah.
Thanks, Dr. Kumar, and good morning, everybody. Let me get my slides up. Great, so we'll start off with my case. It's a 64-year-old gentleman with diabetes, hypertension, cocaine and tobacco abuse, and depression. He presented to the emergency room with suicidal ideations. At home, he's prescribed aspirin, atorvastatin 80, lisinopril, Seroquel, and trazodone, but it's unclear if he's actually been adherent with his medication or not. He is homeless and he's had some recent tobacco and cocaine use and recent stressors, including some family issues and housing issues. So he was admitted to the hospital after admitting suicidal ideations and was in the hospital for a couple of days. And then one morning he developed some substernal chest pressure, which was, so rapid response was called, and they gave him some sublingual nitro, which relieved his pain. They also got an EKG and drew some labs. His EKG is kind of equivocal. It's just got some lateral ST changes, some minor ST depressions in his lateral leads. But what was significant is the troponin came back at 6.6. So we got an echo that day, which was pretty unremarkable. It showed normal systolic function and no wall motion abnormalities. But given his risk factors, his story, and the elevated troponin, we decided to bring him to the lab. So these are some diagnostic pictures, which I'll share with you. So these are pictures of the left system. You can see at the bend and the mid LAD, there is some probably moderate stenosis. And then as well in the ramus, there's also moderate stenosis. I'll show you a few more pictures. And then on the right is the right system. It's relatively normal sized vessel, but in the mid segment, there's also some moderate stenosis. So he essentially had 3 vessels that we had moderate lesions. So we basically decided to do a functional assessment of these lesions. I won't show the images of the first part just based on time, but we tackled the right first. We used a JR4 guide, used a Verata pressure wire, gave him some IV adenosine, and his FFR was negative. It was 0.99. So then we turned our attention to the left system. We used a 6 French EBU 375. used the same Verada pressure wire, gave him IV adenosine, and FFR of the ring was 0.91. So then we decided to tackle the LAD. So we used the same guide, the same wire here, which is in the distal LAD, gave IV adenosine. His FFR was positive at 0.79. So then we decided to use IVUS. I'm sorry, I don't have the run here, but it basically showed calcified lesion with some positive remodeling. So based on the IVUS and the positive FFR, we decided to proceed with revascularization. We ended up using a Cobra 4.0 by 18 millimeter stent, which you can see here. So we elected to use a Cobra stent just based on the questionable adherence with medications in the past, which I'll talk about a little bit more. So this is an angiogram post-stent deployment on the left. And so based on that, we decided to post-dilate with a short 4.0 by 8 non-compliant balloon. And these are just two of our final shots, which shows like no residual stenosis, good stent apposition, and no other dissections or perforations. And then we close with an angioseal, the groin. So a little bit about Cobra stents, because I actually hadn't used one before this case. So it's basically a non-drug eluting stent. It's nano-coated. It's this cobalt chromium stent. And based on some studies, the recommended DAP duration is actually only 1 month. And that's based off of the PZF Shield trial, which basically looked at patients with uses Cobra stent. And at 9 months, there wasn't any stent thrombosis, and the target lesion revascularization was only 4.6%, which is roughly the same for our other drug-eluting stents. And then just in the future, they're currently doing a study called the Cobra Reduced trial that actually just finished enrolling a couple months ago. And it's actually a first randomized controlled trial looking at 14-day DAP duration instead of our usual 6 months or 1 year. So I think this presented a unique strategy for this patient, given his significant lesion, his questionable adherence. We're giving him a chance for therapy, but if he isn't able to stay adherent, there's good data that the stent will remain open. So I'd like to thank Dr. Sachdeva, who I worked on the case with, and Dr. Kumar, I've been working at the VA with all month. So I'll stop here and for questions and comments.
Yes. Leah, we had some good experience with Catania stent before, and now the Cobra stent with this. It's just having a polymer. It's not a drug stent. And there had been several studies in the maybe 15 years ago and 10 years ago. It started in 2006 when they used Catania stent. And so you know that the usage of antiplatelets like clopidogrel and aspirin in some of the patients was only for 1 week. However, there was still some restenosis issues with the stents until they did the Cobra stent, where they designed the stent like the new thin struts and the lower profile. And so it's not only the nanosine, which theoretically maybe it prevents the stent thrombosis and the platelet adhesion, and but also the stent design is a unique one, which made the any stent thrombosis not to happen in spite of the short duration of antiplatelets. So it's a good stent, but now it's coming up also that the other stents, the FDA approved stents, also they had some approval, at least by European Society, that they can be used for a month, like the Medtronic Resolute stent, and also the Excites. And so also the other stents, but they don't have this nanodine, which was an innovation. So you have long experience with or with this stent, or you also part of the study this.
Dr. Magdy, Cobra is commercially available in the United States.
Yes.
So we are not part of the study. The Cobra Reduced trial has just been completed, which is the 14-day DAP study. I think the results are expected at TCT. Also at TCT to be expected are going to be the 28-day DAP trial for Zions as well, which will be anticipated as well. But right now in the United States, the only stent to my memory that has 30-day approval is I think the Onyx, Resolute Onyx, following the Onyx 1 study. And I'm going to again throw this open to the panel and ask, based on the senior trial, was the Boston Scientific stent also approved for 30 days? I'm going to throw it open to the panel. You guys remember?
I think both. I mean, the Zions Prime, it was, at least in Europe, it's approved for 1 month usage. And Resolute, yes, it's also approved. The Resolute came first, and then the Zions came after the Zions Prime. And it is related more to the design of the stent that made the thrombosis is much less. But for the Cobra, it is related to the nanodine polymer
coating.
Yes, that the body, the assume that the body does not recognize it as a foreign body. That's why the platelets don't come on the side of the lesion, and so less thrombosis, less inflammation. And when they came to Egypt 50 years ago, they said if we cover the whole pyramid with nanodine, there was no dust on that. And so the innovation is the polymer, but also the design of the stent was very important.
So I'd like to poll our panel in general, and we'll go through all of you. What's been your go-to choice for short depth? Maybe we'll start with Samir.
Well, my go-to choice when I have a DAPT anticipated problem is intracoronary imaging guided stent deployment. Before we had all this data come out, because I think we want to maximize our procedural outcome so that we have to worry less about stent thrombosis. Having said that, I think stent design, has been panning out to be a factor. So all these latest generation stents, especially Onyx, lately we've been using that because there's some label change as well. And so I think, legally gives you protection, especially in the US. But I think the biggest message is if I have a high bleeding risk patient, I would 100% of the time recommend using imaging and properly use imaging. That's another discussion, is properly using it. But I think those are the 2 points.
The BioFreedom stent is also, as all of you know, I don't know if it is available in the States or not. It's by Biosensor. It also approved for 1 month, and they call it biological stents. It's like biomatrix, but still there's no polymer, and it had a big study, the BioFreedom study, and it's also approved in our area.
Arun, what's your strategy?
Yeah, I like what Dr. Pancholy said. I do agree. Imaging is ultra important, so you get the best apposition and the biggest size stent that you can get in there. I like Onyx and Synergy. I think Onyx, for reasons stated before, I think the senior trial, it was limited. The 1 month was for elderly stable patients. So there was a limited group of patients that was studied for, but that gives me enough confidence to consider that as another stent that I would use.
Kusum, your strategy?
I think, of course, the procedure-related issues and then intracoronary imaging placement is important. But overall, what I do is, if it's acute coronary syndrome, a month of dual antiplatelet therapy, or 2 weeks, and then drop it either to Brilinta or Plavix. Rarely I use Plavix, but in some cases I do use if patient has some issues, there are short-term shortness of breath sometimes in at least 5 to 10% of patients they reported with the Brilinta. Sometimes there is cost issues, those things, and so I just drop it down to one of the antiplatelet therapy. But can I ask you a question about this? This was really a great case. I want to ask panelists about what is our ethical responsibility in doing the cases of non-STEMI with a normal LV function in patients who are drug addicts, non-compliant, because no matter how much we talk about dropping down to one antiplatelet therapy, still lifelong aspirin is important. And in my experience, some of these patients are not taking anything. So it's a class 3B recommendations to do any intervention in patients who are not able to take dual antiplatelet therapy. Then why should we do the intervention? We should just do the medical management until they show their compliance. Because my mentor, Cindy Grimes, always says that you don't have to expedite the death by doing the intervention and causing their stent thrombosis. Just don't do it, because surgeons always say this patient is not like passing the eyeball, so I'm not going to do it. Why not interventionists can say that? Because the patient is non-compliant, have not established the compliant, LV function is preserved, and even one medication is important. Why we are forgetting the aspirin? So what is the panelist saying about our ethical responsibility as an interventional cardiologist?
Okay, so we'll address that. That's a huge point. But let me just poll the other two people who have not had a chance to speak yet. George, and I'm sure George and Dr. Sachdeva will also go into this ethical issue. So what's your go-to strategy for short DAPT, and Sachdeva as well, and then we'll go to this ethical point.
Of course, I'm not putting in stents at the moment, so yeah, it's a little bit different, but my thought is that the smaller the stent struts, the better off you are. That's been shown, the bare metal stent days and so forth. That's a major evolution. And I do think that prasugrel is probably not the best of the antiplatelet agents. Clopidogrel is not the best. I would consider prasugrel in a patient like this as the agent for the short term.
Okay, Dr. Sachdeva.
So there are two things here. One is a patient who is high bleeding risk, and then you can sort of see that whether that patient has presented with the ACS or stable coronary artery disease. The second part is what is the size of the vessel you're going to be treating, and what is the length of the vessel that you'll be treating. I think you have to keep all those things in consideration. And then you want to, whatever strategy you do in terms of stenting, you have to optimize that stent by first making sure that you're doing it for the right reason by doing a FFR. And then secondly, optimizing with the IVUS to make sure that you oppose, IVUS or OCT oppose the stent very well. So all those things are to be sort of kept in consideration. So for example, somebody who is high bleeding risk and has coronary artery disease or has ACS, so you want to minimize their DAPT after a stent. So I would say that if they can go for 6 months of DAPT, that's wonderful. If not, a minimum of 3 months of DAPT, okay? Now, in between, if something happens, you can cut down the DAPT to even 1 month, okay? Now, in a stable coronary artery disease, you can actually use 3 months of DAPT. And if there is, and this is, I'm talking about drug-loading stents, and if there is some change in risk profile, you can actually even cut it short to a month. Now, the vessel size is also important, and the disease, so length of stent is also important, how much you're going to cover. So as we learned from our era of bare metal stents, where we try to use bigger size, shorter stents, less risk for restenosis, with a bigger size and a shorter stent. That would be the ideal strategy in patients. Now, if somebody has probably a 2.5 vessel and they need a stent, probably that's a person you want to treat medically and not even consider. Now, if somebody who has a proximal LAD disease, has a 4.0 vessel, you are sort of inclined towards treating that. And I think in that sort of scenario, shorter the length of the stent, optimizing that stent is the way to go.
Okay, so so you address some of those ethical questions as well. Arun, what do you think about the ethical issues in these kind of patients who are not likely to be compliant?
Yeah, I think that's.
Arun is mute.
Go ahead,
Let
Arun.
me intervene here. We had this issue before when we used to put prosthetic valves for patients who are not going to make INR because they come from remote areas, from small villages. I'm sure you have the same problem in India and some of the illiterate people. And so at some time, we needed at the Heart Institute, where we are the biggest cardiac center there, to decide whether we need to put a foreign body in their body, in their heart, but they don't do INR, and they come back to us with stent thrombosis, or to leave them with a valvular lesion. But now with the education and with more spread of the service all over the countries, and so we cannot deny a patient who is coming with non-STEMI because he's a heroin addict, or because of he's having some depression, that we cannot treat him with the ideal or the guideline recommended treatment. Otherwise, it is also medically or ethically is not possible, but we need to work with that. Maybe we need to do counseling, we need to tell the relatives, involve them with us, but we cannot deny the recommended treatment because of these circumstances.
So before you ask Arun to comment on ethical question, I want to say something about now patients who are non-compliant, or there is a question that they may not be able to take medication or afford medication, okay? I think what strategy we have used is we will actually, hospital, when they discharge, they will provide them 1 month of DAP. So that part is sort of covered. Now in this particular scenario, you know, I think going to a stent which sort of uses or where the recommendation is you can be okay with using a minimum sort of days of DAP was the strategy I chose in this particular patient. And I think it is also unethical to not offer somebody a treatment when you know that this particular person, you have paid due diligence to demonstrate there is evidence of ischemia, there is instability because this particular patient had acute onset of chest pain while he was in the hospital. It's not a chronic stable disease that you're treating. So I think it's both ways. And you have to sort of use the judgment and pay due diligence to actually treat these patients.
Great points. From my perspective, I think it's so many shades of gray involved here, and it's very complex. I think there's different layers of what we term as not good candidates for long-term DAPT. And so one would be the non-compliant, I don't like taking meds, I'm not going to take meds. You doctors are just want to make money off us. Those people, I will try to do very little to those folks. Sometimes you have no choice. If that person has a STEMI, you're going to have to do what you have to do. And so maybe a Cobra stent or an Onyx or some of these stents, you do what you got to do when you coach those people and just hope and pray for the best. Some people, they just bleed a lot, but they'll take the meds. You just know that based on AVMs and other history that they have, you're just really nervous about those people. Again, those people I would go ahead and treat and use some of these strategies. I think kind of going to what Dr. Sachdeva mentions, we have plenty of patients who just can't afford, we're the state hospital, so we get a lot of patients who just can't afford meds. Those people, I agree completely. I don't want to punish those people for not having good financial resources. So it's bad enough that they don't have money to pay for meds. Let's not double punish them. So that's where I would provide the therapy with good intentions and get them. We have the same program. Our hospital can get the patient 1 month of dual antiplatelet. So those people I would go ahead and treat. But just to be totally full disclosure, for this case with intermediate lesions without thrombus, I don't think I would have even FFR'd these. I would have just said, here's some medical therapy. You're not having a STEMI. I don't see any thrombus. Here's some good medical therapy.
I agree with that. I think this was a borderline lesion in a patient who, yes, had chest pain, but was already in the hospital for other emotional reasons. We don't even know what the etiology of the chest pain was. I think I would have made that patient declare himself before I put a stent in and had better evidence that there was really an ischemic mechanism.
Oops, sorry, I have to unmute myself. Okay, there's a couple of questions from the panel that we can take on very quickly. I think there was a question about what about the Orsiro trial and the Zion stent. I think we addressed that issue already. Will you do PCI for intermediate CAD with borderline FFR 0.79 or 0.80? I think that's a difficult situation here. In this case, it was felt that the lesion wasn't quite a typically stable lesion. And so, we had gone on to PCI. In this scenario, I think that was obviously this is the individualized approach. And the last question is there a role for BMS in future as these short depth stents, our data start coming up and there are non-drug-eluting stent approaches? I think that's a complicated question. And really, as my final question before we close this to the panel, I would say, do you all think that there is a future role for BMS? And we'll just go with a yes, no answer through the whole panel.
No.
In this short depth scenario, specifically.
No.
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 George?
No.
Okay, I think we have it no from me as well. Okay, I'd like to thank all the panelists and all our fantastic speakers here today. This was a great session. And for the fellows, I will encourage you to tell your friends about this. We're going to be doing this every quarter. There's going to be a rolling call for cases. We'll have different cases presented, and we're going to be doing this more regularly. Thank you all.
Thank you so much. Thank you all of you.
Thank you, Dr. Kumar. Thank you, everyone.
Thank you.
Thank you.